So today what we're going to practice is a full echo, all right? A bedside echo for a patient. So let's pretend that our young Dr. Biela here came to us with chest pain and that we need to have a look at what's going on. We've done our ECGs, we suspect something's going on, but we're not 100% sure of what could be going on. So that's when our echo comes into it, all right? Now, we are not echo technicians. That takes months of training, actually. It's about actually 2 years of training, sorry. So what we're trying to do is just see if we are in an emergency department setting, what are we going to look at? So this is just a revision and to introduce you guys to the two other views that we use, all right? So thanks, Malusi, for volunteering. You will live on forever. Our grandchildren shall speak of your sacrifice. No, I'm just kidding. All right, so the first thing we're going to do is a subxiphoid view, all right? So the subxiphoid view, what we do, we place our probe just below the xiphisternum, all right? And then we apply a bit of pressure. So if your patient is peritonitic or having abdominal discomfort, this can be quite painful for them. So you've got to take that into account. Now, if you look at the screen, we start getting an idea of what Malusi's heart looks like, all right? So the most important thing also when you're doing ultrasound is just to make sure you can see whatever you want as a complete picture. So if you want to, you can just have a look at the probe here. So you can see what I'm doing is I'm moving it up and down, I'm moving it side to side, I'm rocking it back and forth, trying not to cause too much of discomfort until a point where I can actually get the picture that I'm looking for, all right? Now, what we can, because he's got lovely big abdominal muscles, all right? So you can see I've been doing a lot of ab workouts and things like that. It means that the heart is sitting at about 12 centimeters down, all right? It also tells us that we are going to have to move around a little bit in order to see everything. So sometimes if you're lucky, you can see everything in one go, and sometimes you'll see it in little bits. So let's start with what we can see. So the first thing that we see is the right ventricle. So that's just a bit of gas from his tummy and that it'll eventually go, all right? So here we can see the right ventricle and we can see the right atrium, all right? And there we can see the tricuspid valve that's actually pumping away over there. If we want to see the left ventricle, we have to try and look a bit more posteriorly. And there we see his left ventricle. Now there is a bit of bowel gas, which is fine. It's early in the morning. He hasn't been to the bathroom yet. We understand. Don't stress, you know. So, but these are the pitfalls that you face. So we can see we've got a nice right ventricle. We've got a nice left ventricle. But we can't see our left ventricle 100% over there. So that means we've got to try an alternate view. So the first alternate view that we use is the long axis, which we've already had a look at before. So we try and get in between the ribs, okay, with our indicator pointing towards the left shoulder. So I just want to show you guys. So I'm touching the side of the indicator, right? That what you see over there, that movement. So what it means is that we're actually seeing a mirror image of the heart. The apex is not at the top left-hand side. So in other words, the apex is not here. The apex is more towards the nipple side, right? But we do this just to make it a bit easier for us to envision what's going on, right? But now can you see the difference? We can see a right ventricle. We can see a beautiful left ventricle over here. We can see a left atrium. We can see a mitral valve. We can see a bit of the aortic valve. We're going to try and find the descending aorta. Let's just get it there. There we go. That's a bit of the descending aorta over there. And we can see the pericardium as well. Right? So this is actually the best view in which to get your ejection fraction. And ejection fraction is actually quite easy. So the first thing that we're going to do, let's just freeze this. All right. Now, you can focus on this. Let me show you what we're doing. So this machine, most machines have this little rewind function and forward function. So can you see what's happening there as I move it? I can actually move back and forward a few frames. All right. So what we're going to do is we're going to see this heart in diastole. All right. So in diastole, in other words, at its maximum diameter. All right. And we're going to measure that. So let's put measure. All right. And we're going to measure the width. All right. Let's set there. And we come across and we set there. So we've got 3.5 centimeters. Okay. So in other words, that's our maximum diameter. All right. And then what we're going to do is that let's take it out from there. Sorry, I just need to exit from that. Where's the back now? It's somewhere here. Let's take it out from there. Okay, let's measure. Oh, it's just not moving forward. Right, let me unfreeze it. We'll just get this again. Sorry. So we know our maximum is 3.5. All right, so now we're going to come to our minimum. All right. So we're going to look at how small the thing gets as well. So let's try and catch it there. So we try and find it at its smallest diameter, which is more or less there. And let's just measure it again. All right, so we had 3.54. Has somebody got a calculator out? On your phone? Yeah. Right. So the widest that it gets is 3.54, or let's just say 3.5, all right, just for simplicity's sake. So his widest diameter is 3.5 centimeters, and his smallest diameter is, let's say, 2 centimeters, all right. So for simplicity's sake, the difference is the diameter, maximum diameter, minus the minimum diameter, which comes to 1.5 centimeters, all right. And then you take that, 1.5, divided by the maximum, which is 3.5. So what's 1.5 divided by 3.5? Sorry, 0.42. Multiply that by 100. 42. So 42% is his ejection fraction. And that's how you work out ejection fraction. Simple. Okay. There's another way that we can work it out, and I'll show you guys now. So we're going to concentrate again on, let's just have a look at the buttons here, all right? Yeah, sorry.
Which is the ideal ejection fraction?
Anything above 30% to 80. Not to 80, sorry. Let's say from 30 to 70 is ideal, all right? But you've actually got a very healthy heart because of your running and things like that. So the other way that we can use is that we can use something called motion mode, all right? So I want you to see what happens when I press that. Okay, and we place the cursor in the middle. Okay, so can you see the pattern that forms over there? All right, so this pattern that forms in motion mode is actually showing us basically the maximum and minimum diameter as well. Now they're all together. So let's try and measure again. So we're going to go from here, set, let's go to there, 6.8, all right, because it's measuring the entire ventricle, all right. So that gives us 6.8. Let's just set it there. And then let's take the minimum. Oh, sorry, that's the minimum. Sorry. So this is where the walls are closest together. In fact, sorry. Let me do another one. Let's start with the maximum. Sorry. So we start from there, 6.8. So that's about, let's say 8 centimeters. All right. And then the minimum is going to be from there till about there. So it's about, let's say 4 or so. All right. So it's working out to about 8.2 minus 4.4. So it's just less than 50%. So if we had to work it out using the same formula, so you take 8.2 centimeters minus 4.38 centimeters, the difference divided by 8.2. So it will come out to also approximately there. All right. Now the only way to work it out 100% for sure is to measure a few of these over time. But it can give you a basic ejection fraction, right? So all those fancy ejection fractions that you see, that's basically what they do. All right, nothing else. And you can see ours also gives us an opportunity to work it out, but that's a bit complex. We don't want to get into so much of detail, right? So let's come out of motion mode. So we've had a look at his heart in 2 planes. Now, let's say we couldn't see the ventricles properly for whatever reason. Let's say there were rib shadows or something like that that were passing across like this. Let's say somebody's got very close ribs or something. Then what we can do is we can do something called the short axis. Now, when we're doing the presentation, you guys would have already seen this and the explanation of how the short axis works. But basically what we're doing is that we're looking at the heart in cross section. So we're starting at the apex. So that's the apex of the heart, all right? And then we're slowly but surely coming up, looking at the right ventricle and the left ventricle, all right? And do you see this fish mouth that's happening over there? That's our mitral valve, right? So it gives us a good view of our mitral valve. Then we can move a little bit more. Now his ribs are coming a bit in the way as well, but we can also see the aortic valve at times. So that's more of the mitral valve there, and that's the aortic valve over there, right? And sometimes you can see the tricuspid, but not on him, unfortunately, in the meantime, right? So there we've got mitral valve pumping away over there, right? You can see like a fish mouth opening and closing, and you can see the aortic valve just hiding behind that rib. So it's a little bit difficult to see. So the short axis is very good to tell you the ratio of your right to left ventricle. In his case, you can see we've got a nice D-shaped right ventricle and a nice thick left ventricle over there. That's kind of giving us a good view. There we can see it a little bit better, all right? We can see our septum, we can see everything. So we start to get a more clearer picture of the heart. As you come closer to the sternum though, you lose it a little bit, all right? So this is normally where you'll see the best picture, all right? So we see right ventricle and we see left ventricle. So that's where the short axis is of great value, all right? Now let's say if we want to see the whole heart, the last thing we're going to look at is the apical view. So the apical view, what we do in that case is that we ask our patient to turn onto the left-hand side. So if you can turn onto your left side for me, all right? What this does is this moves the heart anteriorly, just a little bit more. So you're going to basically lie on your left side and come a bit more towards this side. Yeah, sorry, I won't let you fall, don't worry. Okay, now you're going to just come here, just lean a little bit just so that they can see what I'm doing. So what I'm doing now is that I'm basically getting to the apex of the heart and pointing directly through. All right, so I'm going to try and find the apex as well as I can. There we go. All right, so what I'm doing is now shooting through from the apex through to the back of the heart. So what this does, it allows me to see the entire heart in one fell swoop. All right. So what we see, oh, sorry, I put it the wrong way around. That's why it looks so funny. The indicator was the wrong way. All right. So what we see is that we see the right ventricle, left atrium, right atrium, tricuspid valve, mitral valve. And if we move around a little bit, we might even be able to see the aortic valve. Can you see it there? This little thing that's pumping away over there. All right. Okay, can you see it over there? So this is also called the 5-chamber view sometimes because you can see all of the heart at the same time. So this is just to give you an idea, and you can see what a good view it is, all right? Because compared to all of the other views that we had, we've actually got the best view of the heart from the apical view. Now there are some caveats to that. The patient needs to be relatively fit and in good shape like what Malusi is. You can't have somebody with large amounts of breast tissue, adipose tissue. It can become a bit difficult. And sometimes rotation of the heart can make it a bit difficult as well. Ideally, what you want is you want the septum to be absolutely perpendicular so that you get absolutely correct measurements, but it's not always possible in a real setting, all right? So basically what we have now is we've learned 4 different views of the heart. Okay, and those 4 different views of the heart allow you to look at a whole lot of different things. So during this presentation, we're also going to look at stenosis, regurgitation, and things like that. But for right now, this was just to show you a echo on an actual patient. All right, so Malusi, thanks a lot. We really appreciate it. All right, and you've got a very healthy heart. Don't worry.